Okay, good afternoon, everyone. Welcome, welcome. I'm just keeping my eye on the participant screen as it's populating in. Great, great, great. Okay, so welcome everyone as we're getting started. Welcome to the Health Equity Book Club from Karmanos Cancer Institute for the 28th of September in 2023. I don't know what year it is. This is our 11th edition of the Health Equity Book Club. We do it once a quarter. Now, as a bit of a caveat to what I just said, we intended this conversation to be happening in June for Pride Month. Then we hit some technical limitations with our webinar format, and so then we decided, instead of doing a really rushed, bad bad job, we would bump it to the next quarter where we can focus more time and have a great panel, and the technology will work and everything will be better. So here we are in September. We are doing that June conversation that we wanted to have, but we can talk about LGBT people all year long. It's not just a June thing. So welcome, welcome. This is, like I said, our 11th edition. If you want to see our past recordings, all of them are available, including this one later this week, if not tomorrow. We'll be at karmanos.org/book club. That's karmanos.org/book club. I'll put it in the chat in a minute so you can access those if you want. And then today we are discussing Bodies and Barriers, Queer Advocates on Health, edited by Adrian Shanker. I don't know if I'm saying that right because I've only read it, but that's the book we're discussing for this quarter. And for a few housekeeping items before we get started, we're doing our great tried and true Zoom webinar format. So we've got the Q&A, we've got chat, we've got those two tools to interact with the panel. After all the panelists speak, then we'll open it up to community conversations. And also, thank you all for your patience. As we advertised, we were going to do small group discussions this time. Like I said, we hit some technical limitations with the Zoom webinar. We're going to do some more work on that. So look forward to that in a future session. And then, as always, Q&A box. Like I said, I'm trying to get reading my notes. And then after the session, we are going to do a evaluation survey, which will pop up on the screen when I end the webinar. It's a few questions. If you wouldn't mind filling those in, it'll help us make these sessions even better. Also, it has a space for you to recommend books for us to read as a group. So we pool all those book suggestions, and then we pick one based on audience feedback. So come next week or in a few weeks, we'll be sending out a poll asking you which books of these selections do you all want to read, and we pick the one that has the highest votes. Because this is a community project, we might as well try to figure out what our readers want to read. So, all that being said, that was a lot of housekeeping items. I'm going to turn it over to Dr. Michael Simon, who is our moderator for this afternoon. So, Dr. Simon, it's all for you.
Thank you so much, Danny. Danny, can you hear me?
I sure can. Yes, yes.
Okay, that's great. The screen froze on me, but as long as you could hear me, I am here if my screen is frozen for you, but I'm sure it'll come back. So my name is Michael Simon. I am a physician, breast cancer oncologist at Karmanos Cancer Institute, and welcome everyone. I want to just revisit a little history. We first initiated this book club in October of 2020 with the purpose of providing education to health professionals, researchers, and trainees about the impact of structural racism on medical care, and to provide an open format for dialogue between invited stakeholders, which included health professionals of every type, academics, trainees, and community members. Today is our 11th session. We have under our belt 10 books and 1 review article. We are now collaborating and in partnership with the Michigan Association of Genetic Counselors, and we're really proud to be partnering with them. We have also collaborated with the Karmanos Hem-Onc Fellowship Program and the Wayne State University Department of Public Health, and in the past have been interviewed on the radio station Empowered by Angela T. Moore. So we are well aware that issues discussed regarding structural racism also apply across gender, religion, sexual orientation, and ethnicity. In an attempt to expand our discussion, in June of 22, we discussed the book Unwell Women, Misdiagnosis and Myth in a Man-Made World by Eleanor Claycorn. Today, we will broaden our scope as we discuss the book Bodies and Barriers, Queer Activists on Health. The book is composed of 23 chapters written by 26 well-known and emerging queer activists. And this book illuminates the health challenges that LGBT people experience throughout their lives and challenges conventional wisdom about healthcare delivery. The book is broken into different age groups and covers issues faced by youth through older adults. In this brief introduction, I will focus on some data that I thought was interesting and important, provided in the foreword of the book, and then my perspectives on 2 of the chapters. So a few selected statistics. There's a lot of very important information in here, and somewhat shocking information. So among transgender individuals, 40% they indicate have attempted suicide in their lifetime, which is 9-fold the US population rate of 4.6%. So I see that as a very dramatic, disturbing statistic. The second one, in the year 1566, the first documented death penalty for homosexual activity, not the US at that point, in continental North America. And that was a practice that continued until the late 1700s. So death penalty for sexual orientation. The third, in 1952, the American Psychiatric Association listed homosexuality as a sociopathic personality disturbance, and subsequently President Eisenhower, and I knew about that, but I didn't realize that President Eisenhower signed an executive order stating that LGBT individuals were a security risk and could not work for the federal government, almost as they did for Japanese Americans during World War II. My fourth point, as of 2020, there were no statewide anti-discrimination protections for LGBTQ people in 29 states, and an added concern about the durability of federal laws under the Affordable Care Act providing general identity protections. In 2015, US transgender survey, 1 in 3 individuals had experienced a negative reaction from a healthcare provider. So 1 in 3 people going to a healthcare provider had a negative reaction. People identified as transgender in the previous year. In another survey, 46% of bisexual women had been victims of rape, another sort of disturbing statistic compared to 13%. Quote, only 13% for lesbians. The only was my quote, but that's a very high statistic. So the 2 chapters I want to just briefly focus on. In chapter 15, Gender, Cancer, and Me. And if you haven't read the book, that's certainly a book for the Cancer Center members to read. Note was made that LGBT people have higher risk for cancer related to stress and stigma. I'm actually, and another word for that is allostatic load. I'm working with a fellow on a project looking at allostatic load and cancer risk in women in the Women's Health Initiative. So that stress and stigma is hypothesized to contribute to poor health, increased tobacco, alcohol, and other drugs, and poor health, lower likelihood of having a child before 30, which is therefore then a risk factor for breast cancer, having a child beyond the age of 30, higher incidence of obesity, another cancer risk factor, and consequent avoidance of healthcare systems leading to lower rates of screening. LGBTQ individuals also have the added stress of whether to inform their healthcare providers at various times in their healthcare delivery system, perhaps seeing a mammogram tech or a physician or nurse, whether they inform them of their coming out, that they are of their sexual orientation. And therefore, if they don't inform, they might exclude themselves from needed social support. They maybe don't inform because of fear of discrimination, having a bad interaction. In the breast cancer world, also issues include sensitivity towards issues related to bilateral mastectomy, which may be considered gender-affirming surgery by transgender individuals. And I am not certain if our community of physicians recognizes that, how people may perceive hair loss associated with chemotherapy, and also the national focus on the pinking of breast cancer, which may not be acceptable to people from different groups or LGBT community. So that's chapter 15 in a quick nutshell. In chapter 23, Grieving Together, LGBT bereavement support groups, there's an emphasis on the possible and probably common exclusion of partners who may not be recognized by family members or the healthcare system. And again, imagine that you're grieving and you're left out of the room or out of the hospital or out of the funeral because of discrimination, and you're grieving for a life partner. So at this point, I want to give our panelists the time that they deserve and to provide their perspective on health equity concerns for LGBT individuals. So I'm going to first introduce Patrick Yankee. Patrick, him, is the Chief Advancement Officer at Corktown Health. He has over 30 years of experience with managing state and federally funded programs for persons living with HIV. Patrick has held key positions as a consultant to the Michigan Department of Health and Human Services and the City of Detroit. And he spoke when we met just a little bit earlier about how he's involved in training health providers and how to best take care of people identified as queer. So Patrick, you have the screen.
Thank you, Dr. Simon, and thank you for that kind introduction and for having me today. I'm glad to be a part of this panel. This is my first time ever being a panelist at a book club, so I'm going to write this date down and I'll always remember this group. I really enjoyed this book, and I elevated 2 particular chapters, but in total, I'd like to just one, I really appreciate that this book is now it's a good recent example of how these topics are being elevated on regular basis now. I know that in academia, I know the good people in many areas of Wayne State who are working in this areas of health equity. It's happening all over the state. And I think that those of us who are involved in this learning benefit by being together like this. So this is a great opportunity. And I really think these discussions in our state anyway are in its infancy, and that we're really kind of storming and trying to figure out what's the best way for communities to respond, and for researchers in this case to quantify these problems. I think some of the data that Dr. Simon pointed out is very important, but I think there's additional things that we can learn from that, and I hope that that over in the coming years we'll be able to better quantify these disparities. I know there's a lot of structural efforts going on, including the Affordable Care Act, that requires healthcare providers to provide care in non-discriminating ways. And now we have the Healthy Michigan Plan, that's an local extension of the Affordable Care Act, but we also have the important legal support of the Elliott Larson civil rights legislation that's been expanded in the last year to include, at last, after a 40-year effort, to include gay and lesbian people in the Michigan Civil Rights Act. So those are structural things that I think will help us. And so having started my career in community-based organization, I wanted to elevate one chapter, and that's chapter 11, found on page 87. And it's kind of a short chapter, but it talks about social service navigation in LGBT community. And it tells the story of several years ago, a brand new LGBT organization emerging, and the guy who was working there, he was the first employee, and he started showing up for work every day, and he was answering calls from people in the community for a range of concerns, right? And it was a navigation thing. And I see Kat shaking her head because I know she deals with this. And that soon as their shingle or their doors were open, you could say, they started getting calls from community members about things, service that you would think existed, right? And they do exist, but many of the people who were calling them never had gay-friendly services to go to before. So this is a really great short description of that trajectory. And I would say that in this case, they talk about social service navigation. So many people can get so much help just by a helpful conversation with an informed individual. And oftentimes it can end there, but often I think is our experts know that there are a lot more serious needs beyond that, and that when people do have the opportunity to get like focused services that are free from like those other things, they will come forward. And what has happened in the case of many LGBT organizations that say they were existing and their only activity was once a year, they held a Pride Festival or maybe some other community events throughout the year. But when they started opening their doors every day, they were inundated with calls from people in need who weren't going to traditional social services. So I think you're going to see more of that and more formalizing of that in our state, and not just set aside for just gay people, but integrated with the broader human service network. So that's a thing I see happening a lot now, and I think that's really super important. The other area I want to elevate is on page 95, and it's the chapter. It's got a funny little chapter, and it's called That Ass. And it is as funny and humorous as it is. It's written by the book's editor, Adrian Shanker, and it's on page 95. And it really does focus on one area of disparity and really talk. It hits on so many aspects of LGBT medicine and how these can be uncomfortable topics. If you're uncomfortable talking about sex, you're going to be uncomfortable talking about sex, is what I'm starting to understand with people. And that this is an area, or this is a chapter that talks about rectal cancer, colon cancer, and the necessity and the lack of use actually of anal paps, and how One Health Department worked with a community clinic, an LGBT focused community clinic, to increase colorectal cancer screening, anal cancer screening, and that often the statistics in here are rather amazing, and that fewer than a third of people had been screened for that, and that anal paps are not very common, right? And so what we're seeing though now is a turn in this as more physicians, cancer centers implement equity programs that are discussing this. Those numbers are actually increasing. And just to put a local spin on it, I did a little fact finding at Corktown, and we're up consistently over the last 3 quarters in the number of anal paps that are being done. There are structural problems to it, and I'm going to stop talking, is that not every insurance is the same. Right? If you have some insurance, it might pay for some of this screening. If you have a different plan, it may not pay for the screening. So there are a lot of discrepancies among coverage. And those are some structural things that I think we can address if you want to really look at big picture equity. But on a practical level, I think patient education, candid, direct patient education that doesn't fear talking about body parts, can be effective at ways at increasing awareness and making sure people are seeking these things out if they're at risk. And I'll just leave that there for now.
Okay, great. Thank you so much, Patrick. And actually, I was deficit in I introduced Patrick as he, him, and I am he, him as well. And that's now identified on the screen. I appreciate the lesson on how to put that on the screen. So I'm going to introduce now Jessica Chapman, she, her. And I know Jessica well. She is oncology social worker at Karmanos. She works in the breast center. She has a master's of social work and a bachelor's of social work, both earned at Wayne State University. She earned a certification in oncology social work And she has experience as a social worker for close to 13 years, with all of her time spent in the area of oncology. In her current role, she works again with breast, but she also works in the area of gynecologic cancers and the melanoma multidisciplinary teams. Her passion for oncology stems from her own cancer diagnosis as a teenager. She uses her personal and professional experiences to provide psychosocial care to patients dealing with the cancer diagnosis. She has worked hard and volunteered with several organizations, including Gilda's Club, the Blood Cancer Foundation of Michigan, Colors of Hope, Michigan, and Michigan Cancer Coalition of Nonprofits. So Jessica, I'd like to welcome you and turn it over to you.
Thank you, Dr. Seidman. Thank you for that introduction, and thank you for asking me to be here today. I'm so excited. This was a really incredible book to read. And so as I was thinking about what I was going to talk about in relation to the book, I started with like, why was this the book that was chosen for discussion, and why is it important for us to be reading this book as healthcare professionals, but specifically as oncology healthcare professionals? And as we can see right from the beginning in the foreword of the book, you know, it talks about the discrepancy of treatment of LGBT plus folks compared to their heterosexual counterparts. And I think that as medical professionals, it's our responsibility to be aware of that and adjust our treatment of people to make sure that they are getting the best treatment, regardless of what their how they identify. And it was really interesting to read about how, you know, LGBTQ plus individuals are seeing that they have poor health outcomes and increased risk for cancer, and lower insurance coverage rates, which all comes back to, at the end of the day, is as oncology professionals, we're going to be seeing these patients, and how are we treating them in the best way and in the way they need it. And seeing that, you know, they have a lower satisfaction with their healthcare, and how it's provided to them, and that, you know, that's a challenge that we really need to address. And I applaud everybody who read the book and is joining us today, so that, you know, they're getting the knowledge that we need to address these issues. And you know, as I was reading the book, I mean, there were so many good points. You know, the whole book was amazing, but what I kept coming back to as an oncology social worker was, what are some of the things that we as healthcare professionals can do? And so these are some of the things that I gathered from the readings, which, you know, first and foremost, I think, is knowing and understanding that these disparities exist, which I think all of us being here and acknowledging that are a step forward. And again, it's our responsibility to know that, it's our responsibility to learn about that. But I think we have to really be aware that it's not the responsibility of the people who are experiencing the disparities to teach us. Now, certainly they have the greatest education, and when they are joining things like this book club, and offering their education to us, that is amazing. But that doesn't mean that as providers, we can say to our lesbian breast cancer patient, tell me all of the things about LGBTQ people and what I can do, right? Because it's not their responsibility. Just like it's not their responsibility to learn about cancer and how to treat cancer. It's our responsibility to learn about it so that we are treating them appropriately. And in the chapter called "Laura is a Transgender, Didn't the Surgeons Do an Amazing Job?" That one really stuck out to me. And I see this often, is that people use phrasing that either they don't know if it's correct or not, And they're not intentionally trying to use inappropriate language. However, the language that they're using is still affecting the person in front of them. And I thought it was really interesting in this chapter how it was a transgender woman who went to see a physician about something completely unrelated to her being a transgender woman. And this is the topic that got brought up. And she's an outspoken transgendered woman, an activist speaking for all of these things. And in that moment, in that appointment with her physician, she felt like she could not step up and say, that's not how you talk to me. You don't call me a transgender. We are transgender people. Excuse me. And so I think knowing that as professionals, there is an inherent power balance that we have to be aware of. And with that, we have, again, a responsibility to our patients and ourselves to know the information and use it appropriately, which kind of brings me into this idea of knowing the right terminology. I mean, you know, what does LGBTQ stand for? What does LGBTQIA+ stand for? You know, we may not know that, and that's okay. We're not going to know everything, but learning about what do those terms mean, and what does that term, what are all of the terms in relationship to what your patient needs? What do you do when you don't know? Ask. And again, you're asking the individual, how would you like me to refer to you? What are your pronouns? Again, going back to not asking them about the entire community, but you have a relationship with this person as their healthcare provider. And we are able to say, how do you want me to refer to you? What name do you want me to use? Which was also something I kept thinking about through the book, is how, you know, in the medical world, we have our charts, we have legal names, and there's consequences to that for billing insurance and things like that. But how are we addressing that not everybody goes by their given legal name? And where are we communicating that to the rest of our healthcare team? I think often that's something that we're really falling short on, that we really need to do better at as a healthcare system, you know, not just at Karmanos, but in general as healthcare systems. And also really using correct terminology when we are referring to our patients' significant others. Is it their partner? Is it their wife or their husband? I think in my career experience, often I'm seeing people, physicians and such, still using the term partner for a person's same-sex, legally wed spouse. And I think as a social worker, that for me is very important, because that is the first indication of who is the next of kin, who has legal rights, when those topics are going to come up. And so if we're continually referring to somebody's wife only as their partner, the assumption is they don't have a spouse. They have a partner who, while very important in their life, has different legal rights than a spouse. And that changes how we are moving forward with the patient's care and who we can speak to and who can help make decisions. And so just getting comfortable with that terminology, that a woman can have a wife and a man can have a husband, and that's okay. That's the reality, and that's the legal reality now. We know for many years that wasn't a legal reality, but legally now that is how it is, and so we have to get comfortable using that terminology. And I also wanted to bring up, just like Dr. Simon did earlier, about the passage about the pink out things for breast cancer, and how we need to be careful about judging people based on their reaction to things like that. That oftentimes, you know, breast cancer month is coming up. There's going to be a lot of stuff around, you know, the world, but in healthcare, in oncology, for our breast cancer patients. Pink socks, pink notebooks, pink everything, and gifts for our breast cancer patients. And that may be very invalidating for some people, and it may come off as people being rude or ungrateful. And, you know, often the instinct is to judge what's going on and being like, well, that person is just rude and they are not grateful for all the things that they're getting. When in reality, we don't know what anybody else is going through. And so we have to really check our judgments on things like that. And so to end my talk, I just wanted to say, I thought this was a really great quote that really encompassed the whole book and why we're all here today. And it's in the chapter about chapter 14, without wincing or clenching. And it says, the author says, at the end of the day, that's what any bisexual, any LGBTQ person and human being deserves. Access to an affordable, non-judgmental medical provider who will offer and provide tests as requested and needed, without wincing or clenching, when we are honest with our providers and ourselves. And that was one of the most poignant quotes to me. That's what I strive to be as a social worker in this field, and what I hope all of us as healthcare providers are striving to be while we're taking care of our patients.
Great. Thank you so much, Jessica. Okay, I'm going to introduce our third panelist, and maybe we're running a little late. Maybe I spoke a little too much in the beginning, but I want Kat Mayer, identified as they, them, to have their proper amount of time. So Kat is the program director for MyGen, Michigan's only nonprofit dedicated exclusively to caring for LGBTQ plus older adults. As a member of the LGBTQ plus community, they are dedicated to helping to provide safe and vibrant opportunities for LGBTQ plus older adults to engage with others in the age and place. Kat has a Master of Social Work from the University of Michigan with a focus in social policy and evaluation, and was a geriatric scholar. They have a background working in senior housing preservation, immigration law, and skilled nursing care and rehab. And I will let them tell the rest. Thank you, Kat.
Hi there. So thank you to the other panelists too. It's so interesting to hear the different parts that really stand out to folks, and I resonate with a lot of it. So there's a lot of different things I want to touch on in this, but I know we only have so much time, so I'll try to focus it. So one thing I want to start off mentioning is I want to reframe one aspect of the conversation. So when I read this book and a lot of similar works, we talk a lot about people fearing being stereotyped. And I want to examine what that means when we talk about that. So when we talk about fearing being stereotyped, where does that leave folks who maybe fit these stereotypes? What if you are a slutty bisexual? What if you are a gay man with HIV? When we say we're fearing stereotypes, what we really mean is that we are fearing that we will not receive attentive, appropriate, responsive, and personalized care that is free from judgment and discrimination. So when we think about how we're approaching these things, I want to reframe it from thinking about don't stereotype people to how do we treat all of our patients in a judgment-free way that allows them to tell us the information that we really need. Think about it, just something anyone could relate to. Talking to your dentist about if you floss or not. Like when your dentist clearly is shaming you for it, you might be more likely to lie to them You know, if someone clearly is displaying to you that if you are sexually promiscuous, I'm going to have a judgment about you or blame you for your sexual health, you're less likely to tell them the truth. So all of these things come down not just to a fear of being stereotyped. Fear of being stereotyped is not specific to the LGBTQ community, but it's something that we need to think about across sectors when providing care. So given that, there was a few different aspects that really stood out to me. One was, I know was already mentioned, was the chapter about Laura's a transgender, didn't the surgeon do an amazing job? So that one really stood out to me for a lot of ways. It reminded me very specifically of an instance that I experienced, where when I was working in a nursing facility, we had our first transgender woman who was out and came in. And now this woman had medically transitioned decades previous. She was one of the earliest people who had transitioned. Her name was legally changed, her gender marker was changed, you know, for all, but someone at the facility, well-meaning, took it upon themselves to tell everyone who worked there that she was transgender. She was very well-meaning. She was trying to say, hey, be careful, be aware. But because of that, people went in with all of these biases or went in only wanting to ask her about her experiences being transgender out of maybe sometimes curiosity, sometimes disgust, sometimes, you know, whatever they were bringing to it. And it made it so her time there was spent explaining herself over and over and over again for really no purpose. Her care completely became about her experience being transgender, and she never even had a say whether or not she wanted to divulge that information to anyone. So I point that out because a lot of times even well-meaning actions can cause issues. However, I also want to bring that back in a more positive light to the chapter Without Wincing or Clenching, Bisexual People's Experiences with Healthcare Professionals, by Robin, I don't know how to say their last name, Oaks. And they talked about an experience where a provider didn't get it right, but that they showed that they cared and were learning. And I want to point this out because I think a lot of providers, I mean, even myself included, we fear getting it wrong so much that we don't try at all, that we avoid the topic completely so we don't have to worry about messing up. And so in this example, this person their physician had asked, do you have sex with men, women, or both? And the person responded with all, because gender is not binary. It, you know, there's multiple there's first of all, there's intersex folks, there's people who are non-binary or trans, there's so many different ways that could be interpreted. And that wasn't a major mistake or anything, but it still was something that stood out to that patient and has stood out to me in the past as someone who myself, I'm bisexual and polyamorous. I have one of my partners is a trans male who has medically transitioned in many ways. I have other partners, you know, it gets complicated. But that provider responded by saying, you know, I hadn't thought about the effect of what I said there before. Thank you for pointing that out. I will adjust how I say that in the future. And so even though they maybe made a misstep, the fact that they showed that they cared and were attentive instead of just being embarrassed and not wanting to talk about it and avoiding it, they took that moment to acknowledge and thank that person, and then presumably, I would hope, go on to learn more about it themselves. And so that's really the thing I want to highlight that this book talks about, is when we are trying to correct issues in this, a lot of times what prevents people from taking action is this avoidance. So that's something we need to work on. Another example I want to give is a difference between, or an example of why people might not trust an organization, even a well-meaning organization. So for instance, myself, I went to the dentist the other day. I love my dentist. I keep mentioning dental care because it's on my mind. But the dental hygienist happened to be a trans man. And they asked me my pronouns, which this dental office hadn't asked before, but they clearly had it set up in their system that they could do that. And so they asked, they updated it in my chart. They showed me that they updated it in my chart. things all over, their office indicated that they're LGBT friendly. And then I went up to the front desk to check out and set up my next appointment. And I was misgendered. I was using like names that I didn't want them to use. It was completely ignored, even though it was right there in front of their face. So this doesn't just come, that needs to be addressed from so many levels, from a management level, from the level of the people working on the ground. We need to try. Because the only way we can really build trust is by walking the walk. And when we think about building trust, it takes time. We have to spend the time to create this change, to be humble and admit when we make mistakes, and to seek out knowledge like everyone here is by attending this club. So I could talk about so much more, so much more. This book was really rich, but I will leave it there.
Okay, great. Thank you, Kat. So this is the part of the session now that we're looking for questions and answers, or questions from the audience. And we would like every one of the participants to feel comfortable to put a question in the QA session or in the chat section. And if you'd rather speak the question, we have the facility to do that as well and to engage in the conversation. I don't see any questions at this point, but hopefully they will come up. Maybe I could direct a question to Jessica, thinking about our healthcare system. Would you say that we're an LGBTQ friendly system? And how we're operating? What do you think we should add to our process, our intake process?
Yeah. So I would say before I came here, was in a Catholic health system. And I would say 1,000%, we are doing it a lot better over here. We are a lot more welcoming, which is fantastic to see and fantastic to be a part of, because there are a lot of challenges that can be identified working within that type of system. So I think we're doing great. I think one of the things that we really do need to do a little bit better is, kind of like I alluded to earlier, is I know we're asking pronouns on paperwork, but where is that going, right? So like Kat was mentioning earlier, that when we're asking that information should be easily accessible to everybody on a screen, so that when somebody pulls the patient up, we see what their pronouns are, so we know how to refer to them. We see if there's a preferred name that they want to go by, so that we can be more inclusive for our patients. I think we're great at communicating amongst each other when we have that ability, but making sure that everybody has access to all of that information.
Right, and maybe make sure that we not only have access, but that we look at the information, and think about the information, get it as part of our organic behavior as healthcare professionals. Any other comments on that? And maybe you're not, the other speakers are not at Karmanos, but what would you say would make your healthcare providers more open and welcoming? What kind of things, I think Kat spoke about this a little bit at the dentist's office.
Yeah, so I think there's a lot of things. One thing I forgot to mention when I spoke, I just want to mention real quick, just because I know this is a cancer talk or organization, is another thing that comes into play is just lack of knowledge. Like, for instance, trans women experience higher rates of breast cancer than if they hadn't transitioned. So people don't even realize that. They don't even think to tell a trans woman she needs to be screened, because people don't know, because there's so little research. But I think a lot of things are, one, being openly, they talk about this in the book a lot, but being outwardly acknowledging that you are LGBT friendly in some sort of visual way, because people who are not afraid to display that visually. I have been in doctors' offices with very clearly like discriminatory materials on the wall, you know, and it is absolutely essential to say out loud that you care about folks. And if you're not willing to do that, then you probably don't care. Quite frankly, that's the message it sends. So there's that. There's also on your intake form, asking questions about sexual orientation. You know, we talk about the lack of knowledge we have in a lot of areas, and that's because we're not asking these questions. How are we going to track if gay or trans or lesbian or bisexual people are experiencing discrimination if we're not even tracking that they exist? You know, so how are you going to know if you're serving your folks well if you don't even know who your folks are? So there's a lot of things. And then in the questions you ask, you know, try to ask things broadly, like Jessica was mentioning, you know, with the partner situation. I have had that come up. Some people might still want to refer to their husband or wife as a partner for protection reasons. It's good to ask them, like, how do you want me to refer to your partner? You came out to me as your physician. Are you okay with me telling that to other people here, to other providers I might be coordinating care with, to your nurse even? You know, not just because someone came out to one person doesn't mean they want to come out to everyone, you know. So it's being really conscious of these things, having the conversations, not making assumptions, and being willing to adjust. I would say.
Yeah, and certainly, you know, a way to broadcast information is to put it in the medical record or the electronic medical record, then all of a sudden it's available to anybody that looks at it. And how comfortable is our patient with that? And that could be a discussion we have, but just asking sexual orientation is one of our intake questions. You know, I'm pushing our trainees to ask occupation at least, you know, just to find out something about our patients. Patrick, do you have any comments on what's just been said?
Sorry, I was dealing with a technical problem. I agree with a lot of what I've heard. I think that I encourage all LGBTQIA plus
If you could hear us, I think you froze, Patrick.
Yeah, and hopefully he'll get back on. And Patrick, if you could hear me, once you get back on, please speak up. Let me let's see. And Danny, are there any questions in the chat that I'm missing?
No, but can I take a second to brag on Karmanos a little bit?
Yeah, please, and go ahead and ask the question.
So I'm gonna turn my camera on, so I'm not just a black square. So for my office is cancer research, training, and education, and our job is to try to figure out where people are falling off their cancer careers, either before they ever start or in their trainee phase, in their junior faculty phase, senior faculty phase. So for the very first time in 2022, we did a KCI faculty diversity survey and asked faculty their sexual orientation and gender identity. And there was some pushback on that internally, but we got it done. And we were able to point, for the first time, we had faculty who were comfortable to identify, at least in an anonymous setting, that they identified as LGBTQ in some way. So it's a small group, but they exist. And so that was just pleased me to no end that we did it. And so we're starting to have the numbers and we can count. And that's what matters to me right now. Okay, that was the brag. Bye-bye, back to the squares.
So maybe, you know, I think Pat brought this up, that how do we know, you know, what the scope of the issue is if we don't identify people? And I guess I'm being careful not to say problem, because it's not a problem to be LGBTQ, but maybe it's a problem if that's how you identify and it's not recognized and you're not being provided the proper care. And I in the book they mentioned that it's not in any of our health registries, but they the book, and I don't know if anybody remembers the exact part that it was in a California registry. I don't think it was a California Cancer Registry, but a California Health Registry that they asked people and had data. And the book does go through lots of different surveys that were delivered to target populations. That seems to provide some good data.
Yeah, I will plug for my gen. We do provide trainings that specifically talk about data collection and how to do that in an affirming way. So if that's something anyone is interested in, we have CEUs and trainings and things that you could access through us.
And that's data collection for populations.
Mm-hmm.
But it could also be a data collection for our healthcare professionals.
Yep. Mm-hmm.
Patrick, I think you were saying initially, before the official session started, that you're involved in training healthcare providers on how to be more appropriate in the setting of queer LGBT individuals. Can you speak to that for a minute and what's involved in the training?
Is Patrick here?
Oh, right. Patrick was off.
I think we lost him.
Okay. And Pat, do you or Jessica have any response to that comment? And I know, Pat, you talked about training people.
I'm sorry, can you repeat the
the question had to do with, I remember earlier Patrick was talking about that he's responsible for training, I think he said training physicians to be more sensitive to issues faced by LGBTQ individuals. And I was just wondering, what does that training consist of?
There's a panelist or attendee right now who would be great to talk about that, our training manager. But she might be mad when I say this because in case I'm saying it wrong. But yeah, we talk about a lot of different things. So I mean, one, just like general terminology. I mean, and giving people a space to ask the questions that they're afraid to ask anywhere else, because that's the only way that you learn. So there's a lot of kind of basic understanding about, pronouns, terminology, what does it mean to be transgender, etc. It can be about how to ask appropriate questions, how to have a conversation about difficult topics, how to understand the extra barriers that folks may have, which I don't know that we've talked about a ton in this conversation, but LGBT folks are more likely to experience difficulties with access, like due to transportation, due to lack of caregiving support, we talk about found family a lot with queer folks, but that tends to be around the same age. If you're 80 and all your friends are 80, who's taking care of you? How are the referrals we're making being sensitive to that? Acknowledging the unique experiences that you may have, acknowledging the lack of insurance, really connecting holistically as a person. I think a lot of times in healthcare, the past 20, 30 years, we've talked a lot more about person-centered care and having an interdisciplinary approach. And I think that's so important for health outcomes for, LGBT folks or people of any marginalization, because it's not just about what happens when we walk in the clinic. It's how many barriers do we have to even get to that clinic? How many barriers do we have to follow the recommendations of someone? You can tell me to eat fresh fruit all day, but if I can't access it, I'm not going to be able to manage my diabetes like you want me to. There's so many ways that we need to think beyond just what's on this piece of paper and think about this whole person in front of us.
Okay, thank you for that. Pat, I don't imagine you've gotten back on the system yet. I was also thinking, I think it was a comment made by Pat, and I think he commented on the chapter 12, the anal health, the chapter about anal health for the LGBT community. And there, and I actually had not thought about anal PAP myself, although when I round in the hospital, I see patients with anal cancer. And actually, I don't know if everybody knows that, I think the cure for anal cancer, which could be cured by radiation and chemotherapy, was developed by one of the founders of our cancer center here. And I'm wondering if, we have a high-risk breast clinic where we're trying to find out who's at higher risk that may need genetic counseling and maybe need MRI scans, and asking the question about colonoscopy. Perhaps we should also be asking the question about anal health and whether, an anal pap is necessary. We should really widen that. Any thoughts about that? Maybe Kat, what are your thoughts?
Yeah, I hadn't heard of that either. And that really blew my mind because it made me realize how little we know about LGBT related healthcare in a lot of ways. I just had a conversation with Jay Kaplan from the ACLU because we're working on training volunteers to help with gender affirming insurance denials. And I was wondering, like how much activism can happen around that type of, is that not essential care, like in the same way that, a vaginal pap is, so there's so much. And again, it kind of goes back to my concept of making sure you're asking questions of orientation and gender identity when we're doing research, because providers only know what the research out there is telling that, we're hopefully past the days where we were doing just kind of research as it became, and asking forgiveness later. So we need to be emphasizing to funders and to people funding research the importance of these things and the importance of investigating this work more. And yeah, we need to be asking patients and then petitioning insurance companies to be covering these things. If you want to see better effects for your patients, you need to be willing to stand up and give your opinions and thoughts and put that energy beyond just in your office, but also to the people who have power over these things wherever you can, especially physicians, because your expertise is going to be taken a lot weightier than a program director from a queer organization, unfortunately.
Right. Or maybe they should be given as much weight. And I know in another 30 seconds or so, I need to turn this back to Danny, who will close this out. And as we promised, we'd like to finish in an hour. I was thinking when you mentioned research that I'm involved with the Women's Health Initiative, which is 168,000 women study or people identified as women. And I don't know off the top of my head. I've been very involved with this study. I'm the special interest group for cancer leader, and I don't know off the top of my head if there's been studies on LGBTQ and sexual orientation in that study. That would be really interesting to look at, and I think an important issue. Such a large group. So Danny, I think at this point, did I miss any? There were some comments in the chat that I think were important in reaction to some of the statements. Maybe I'll say really briefly, thank you to everybody. Thank you to our panelists. Patrick, if you can hear us, I'm really sorry that you got cut off, but we really appreciate your input as well as Jessica and Kat. So Danny, do you want to close this out, please?
I sure can. Thank you so much, Dr. Simon. Thank you so much to our panelists. It always feels like it's never enough time to cover these topics, so we just open these ginormous wells of knowledge and then we can't go very long. So I do appreciate everyone being here, all our attendees that have stuck around. When you go to exit the session, the pop-up will appear for the survey. It's just a few questions. It would really help us to figure out what we need to do for this book club to succeed. And then what books do you want to read next? We pool your suggestions and we send out a poll and we pick the top ones. So feel free to send us all those things. And thank you all again. And we'll see you the last Thursday of the business quarter next time, which I don't know right now, but I'll send an email. Thank you all. Bye.
Bye. Thank you so much.